Hello, everybody, and welcome to our TIF Talk tonight. I'm Andrea Millers with Endogastric Solutions, and I'm very excited today to have Dr. Bradley Freilich. He's our guest tonight, and he's from Kansas City. And thank you so much for being here, Dr. Freilich. We really appreciate it.
Oh, thank you for inviting me. It's my pleasure.
Thank you. So just to give you guys a heads up, this is a live event. So at any time, if you have any questions for us, please feel free to enter your question on the comment section, and we'll do our best to answer any questions that come in today. So Dr. Freilich, let me tell you a little bit about Dr. Freilich. He's a board-certified, fellowship-trained gastroenterologist with a special emphasis on hepatology, liver disease, weight management, and GERD. He leads the Kansas City Research Institute, a leading site in liver disease and digestive disease states. Dr. Freilich is a well-known academia and researcher, credited with numerous articles, presentations, talks, and research projects on various projects or aspects of liver disease. This distinction ensures that patients under his care have access to the latest treatments and technologies. So again, welcome, Dr. Freilich, and thank you for being here tonight for our TIF Talk.
Oh, thank you.
So let's go ahead and kind of start. Can you talk to us a little bit about what is GERD? You know, what are the symptoms that patients could potentially feel? What are the things that they what are the symptoms that they could have? So talk to us a little bit about GERD.
Sure. Well, most people know that indigestion and heartburn are probably the two more common phrases that people express this phenomenon that occurs when the stomach contents actually come and rise up into the esophagus. And that's why the acronym GERD is what it is, because it stands for gastroesophageal reflux disease. Reflux meaning it's actually coming backwards up and it's causing a disease state, which is a state of dis-ease where people do not feel well. And the most that people get is heartburn. And heartburn can be described by people in so many different ways. It can be something where they say it's like a hole in my chest. They can talk about like they're on fire. They can have a sense that there's just a fullness in their chest. And they sometimes just call it indigestion. And some people don't know how to describe it at all. They just have a sense of feeling bad. And it's one of those things that if you spend time enough with people that have this, you realize that everybody has a different way they perceive it and they have a different way that they can express it.
Right.
We also see, you know, these very kind of variable presentations that are not typical of the true burning feeling that people get. There are atypical symptoms, we call them, where people may present with things like nausea, or they may actually just be belchers, where they're clearing the acid out of their esophagus and they're belching all the time and they don't even realize that they're having acid reflux. And then there are these people that have symptoms related to their upper tract, what we call laryngopharyngeal reflux, or LPR, where people have a feeling like there's a knot in their throat, that they have a mucus in there that they're always trying to clear out, or they have a cough. A chronic cough is a very common way that people present with this. And even sinus problems or feeling of burning that they get. And then, of course, there are the people that wake up in the middle of the night actually regurgitating acid up into their throat, into their lungs, and into their sinuses. And when that happens, people know it and they are very unhappy. So those are all the spectrum of different ways that people can present.
Right. Thank you. So can you talk a little bit about what you recommend, you know, patients that are suffering from? How do they manage their GERD initially? What do you normally recommend? Do they change, you know, do they change the foods that they're eating? Do they do lifestyle modifications? Any activities they should stay away from? what do you normally initially tell patients to do when they're first starting to feel these symptoms?
Yeah. Well, a lot of times now we see that people go to the internet and they start reading about what this is and trying to figure out what they should do. And there are some variable information out there. Some of it's good and some of it's probably not so good. And it's hard for people to discriminate, proper information that they should absorb for themselves. But what we know is that the basic problem of gastroesophageal reflux disease is that there at the bottom of your esophagus, there's a muscle called the lower esophageal sphincter, and it relaxes too much. It's not what we call competent, it's incompetent. So it doesn't do its job. And it relaxes too much and it allows the contents of your stomach to rise up into your esophagus or higher. And the two things that are really associated with that is one is a genetic component. I mean, there are people that will just develop that lower esophageal sphincter problem, and they will have it and they can eat foods that other people can eat and have terrible symptoms. And so it's not necessarily food related in those people. But then there are other people who actually are very sensitive to eating certain foods. And so we don't really know why. There's probably a chemical component to some foods, and certainly there are an acidic component to foods. There are very common lists of foods that cause people to have acid reflux. And if people avoid those foods, many people actually get dramatically better.
Okay. Yeah, that makes sense. Now, what about when people say, if you start having kind of symptoms or feeling, funny, there's people that talk about, keep your head up late, don't go to bed, 3 hours before you eat or right after you eat or whatnot. Are those things, does that really help people that are suffering from acid reflux or GERD essentially?
Yeah, well, it does. I mean, and so if you think about the physics of this is that if you're standing up, it's less likely that you're going to be able to regurgitate things up against gravity as easily as when you're lying down, and things can flow a little easier in the direction towards your head. So gravity, by keeping your head of your bed elevated, can help. And then having your stomach be empty before you lie down is also helpful. So there are people who may not empty their stomach as fast as others. And those people, a lot of diabetics, for instance, with an entity called gastroparesis, where their stomach doesn't empty, they have a lot of reflux because there's a lot of acid that's just sitting in a pocket. The other thing that happens is that people actually have hiatal hernias. And we know that by looking at people with endoscopy, looking inside people's stomachs, we find that part of their stomach rises above the diaphragm. And they have this little pocket called a hiatal hernia. Acid pools in there and it doesn't clear very well, and that can regurgitate up. And that's a problem with the diaphragm. The hole that the esophagus runs down through is just a little bit too big, and the stomach can slide up in there and it can go up and down. It's called a sliding hiatal hernia. Some people get them where they come up and they stay up, and some people get it where their whole stomach will be in their chest. And all of those things can predispose people to acid reflux.
Okay, thank you. So what options right now are available for treating GERD? We kind of discussed the different options now. I mean, the PPIs or medical therapy versus, surgical therapy, obviously the TIF procedure we're here to talk about today, but can you discuss kind of what are the treatment options today?
So the treatment options, I mean, the mainstay of treatment is really dietary changes, number one, because everybody can do that. Number two is trying to suppress the amount of acid that your body makes, because if you don't have as much in your stomach, then even if you're regurgitating, it's not going to create nearly as much discomfort. And the medications, there are really 3 levels of medications that exist out there for people. The number one lowest level of effectiveness are antacids. So people can buy those over the counter. Tums, Alka-Seltzer, and Mylanta, those Gaviscon, those are all antacids. Then are the H2 blockers or the histamine receptor blockers. Those are over-the-counter medicines as well in the form of Zantac or Tagamet or Pepcid. Mm-hmm. And those actually can work well, but not as well as the drug that blocks down the production of acid completely, which are the proton pump inhibitors, the Nexiums, the Dexalants, the Zegrids, the omeprazoles of the world, the Prilosec. All of that are drugs that completely block the ability of this cell in your stomach, called the parietal cell, to pump acid out into your stomach. Well, unfortunately, although those drugs work well, we've learned that there really are some long-term complications of taking those medicines. Osteoporosis and increased risks of infections, upper respiratory infections, because you need that acid to kill bacteria. And if you don't have that, and there's bacteria, it can reflux into your lungs and cause upper respiratory infections. We see increased risk of C. diff infections or Clostridium difficile infections in people's colons. And we also have some data, soft data, albeit, that there may be an association with dementia and kidney disease, although that data, in my mind, has not been very well validated. It is something for people to be aware of, and we are telling people they can't be on these medicines long term. It's not safe.
Right.
So in our practice, really our approach is, can we change people's diets and get them on H2 blockers and have their quality of life be fine? And if the answer is yes, and they're happy with what they're doing, then that's how we treat them chronically. But a lot of people don't have quality of life with doing that. They don't want to restrict all of these foods, and they don't want to have to take pills every day, no matter what kind they are. And that's when there's an opportunity to actually change the mechanics of what's happening. And that's where we start getting into the possibility of doing mechanical surgeries on people to improve their situation.
Perfect, thank you. Can you talk a little bit about those different options after medical therapy? There's obviously the TIF procedure, there's Nissin, and maybe let the viewers kind of know the differences of the different treatment options on that side of the spectrum.
Right. Well, the mainstay of treating what we call refractory GERD or chronic GERD reflux is to, in most people, fix the hiatal hernia. About 85% of people that require some type of mechanical surgery have a hiatal hernia. So that stomach comes down below the diaphragm, and we can sew up the defect in the diaphragm so it's smaller and the stomach doesn't come back up. And then the second step is to create a little bit of a tightness around that valve that exists between the stomach and the esophagus. Mm-hmm. And historically, it was done through a procedure called the Nissin fundoplication. The problem is that procedure is associated with a lot of symptoms afterwards. People have what's called gas bloat. They can't belch, they can't vomit, and it's very, very uncomfortable. They can also have problems with swallowing afterwards, and that's called dysphagia. So, and then the procedure itself breaks down, and the majority of people after 5 years are back on their medications after a 5-year period. Yeah. So that's not a great option for people because of the issues associated with this failure and the symptoms. There's another option out there called the Lynx, which is a magnet that goes around the esophagus. And in certain instances, that's a very good procedure for people. But what we're finding is in some of the post studies that there is late ingrowth that can occur with these magnets. They can grow into the tissue, and it actually causes more fibrosis and scarring. It makes it ineffective, and it gives people problems with swallowing. So in some people, that procedure is growing out of favor. And then what we have is the endoscopic fundoplication, which TIF, which stands for trans oral, through the mouth, incisionless, not cutting through the body fundoplication. And so it's this opportunity for us to go down with a device connected to an endoscope and to take tissue and to kind of oppose it to each other in a slight bit of a twisting fashion and stapling with some plastic staples. They're much like what we see when we fasten the tags to clothes, those kinds of little plastic fasteners. And this procedure has actually been around for over 10 years. And there's really great data showing its durability, its effectiveness, and its lack of all of those other side effects that we've seen with Nissin fundoplications. So we don't have a problem or the inability to vomit, and we see really long-term durability.
Fantastic. Thank you for that. So we do have quite a few questions that have come through. So I'm going to go ahead and kind of ask you some of the questions that have come through, if you don't mind. From Abby, she's asking, how fatal is GERD? How frequent should a patient undergo endoscopy?
Well, fatality is not something we usually think of when it comes to GERD. People that have reflux have a higher predisposition to having what's called Barrett's esophagus, and that is a condition that can be precancerous. You don't have to have any symptoms of reflux to have Barrett's, in fact. But we do know that if you do have reflux, there's a higher chance of having Barrett's. So if you have chronic reflux, you should have at least at some point in your adult life upper endoscopy to see if you have Barrett's. If you don't have Barrett's, you're not going to get esophageal cancer, and there is no risk of mortality associated with reflux.
Perfect. Thank you. Asking, why is it so painful with very bad nausea sometimes? I'm in bed all day with it. I think she's saying, why is it so painful to have GERD?
Yeah, well, there are nerves in your esophagus, and those nerves get irritated, and it creates that discomfort. And when the esophagus gets injured, those nerves are even more vulnerable to any kind of irritation. So if somebody has damage to their tissues, they're going to feel those symptoms for a lot longer and with very little irritation. Just even drinking water for some people can cause them to have some symptoms.
All right. Perfect. Thank you. So Marius is asking, does acid reflux cause shortness of breath? And then also, how long do the benefits of TIF last?
If you have microaspiration of acid into your lungs, which occurs in some people, they actually present with atypical asthma type symptoms. You get inflammation of the small little breathing tubes in your lungs that go into spasm. And people can have chronic cough, and they can have some shortness of breath if they are chronically aspirating or if they're having damage from that acid. Now, of course, there are many other reasons for people to have shortness of breath. So if that's occurring, please make sure it's not your heart or you don't have a primary lung problem. And that's a question that you need to be asking your primary care doctor. But it is one way that reflux can present, although it's probably one of the least common ways that it can present. And when it comes to TIF, we have data out for 10 years that shows it has great durability in terms of its ability to keep people off of medications and to have people be symptom-free.
Perfect. So we have another question from Mike. Can you just fix my hiatal hernia and fix my GERD? So without the TIF?
So not really. I mean, there are cases where a hiatal hernia is so bad that the esophagus gets shortened where we can't do a fundoplication because it's physically not possible. That is rare. The vast majority of people need a fundoplication in order to preserve that valve and to prevent the reflux and to actually help to anchor the stomach underneath the diaphragm so it doesn't recur in the hernia doesn't go back up in there again. So the
Okay.
two really need to be done together.
Okay, thank you. And then from Tina, what is gastritis?
Gastritis is an inflammation of the actual stomach. So you have your stomach cavity that drains into your small intestine, and then above that is your esophagus. So that's just inflammation further down in the lining of the stomach. And that really typically does not have symptoms at all. We see that in people that may develop ulcer disease. And that's a lot of people come to us and they say, I've got ulcers. And they think that they have chronic ulcers, but they really just have reflux disease.
Interesting. Okay. Another question. This one's from Shane. Will TIF help with Barrett's esophagus?
So there's no data that TIF will help with Barrett's esophagus and making it go away. And in fact, there's really no good data showing that stopping acid, being on proton pump inhibitors, can cause regression of Barrett's either. We do have other techniques to get rid of Barrett's. We can actually burn the lining of the esophagus to get rid of it. But we only do that in cases where the Barrett's is actually starting to get precancerous. When we look at Barrett's, there's something called dysplasia. And if most people are familiar with pap smears, when a woman gets a pap smear, if they have a bad pap smear and they have dysplasia, they get treated. Same thing with Barrett's. If there's no dysplasia, all we do is go in every 3 years and take samples and make sure we don't get angry-looking cells. If we start seeing dysplasia, we can take care of it, treat the Barrett's, and then we can go in and take care of the reflux and treat people with hiatal hernia repair and a TIF.
Fantastic. Thank you. Another question from Frank. He's saying, very interesting points regarding the PPIs. I'm on them for 15 years and I'm seriously worried about it. What are the benefits of TIF versus Nissin in terms of recovery time and healing?
So the Nissin, again, you're going to get a hiatal hernia repair and then you're going to get a fundoplication. The Nissin is one form of fundoplication. You mentioned that it causes a lot more side effects afterwards that are long-standing, and it's much less durable than a TIF. TIF is not associated with those long-term side effects, and it has greater durability. It's also done endoscopically as opposed to surgically, so there's less chance of causing damage to the nerves on the outside of the stomach, the vagus nerve, which can cause the stomach not to empty as well.
Okay. Perfect. So we've got another question this one's from Rosie. I had the TIF on September 15th this year. I still have very bad acid reflux and have to take famotidine. Why would I still have reflux?
So about 5% of people that get a TIF don't get a complete resolution of their symptoms. One of the most common things that we see is that those people actually have underlying gastroparesis. So the stomach is not emptying well. And a lot of people that undergo the procedure don't actually get tested for that. And it's important that you ask your doctor to test you to make sure your stomach is emptying normally. If in fact it is, it's possible to go back and get a revision done to actually tighten up that area a little bit more, and so that you're able to have the acid reflux from stopping.
Wonderful. You're getting a lot of questions tonight, Dr. Freilich. This is probably the most questions I've ever had on a TIF Talk, so I hope you don't mind. So we've got another question. This is from Tara. My husband had an EGD, and they said he has grade B GERD. What does that mean? Should he be seeing a GI or a general surgeon moving forward?
So there's no such thing as grade B GERD. That actually refers to the amount of damage, esophagitis. So there was actual tissue damage there that was involving about 25% of the lining of the esophagus. If that is occurring, then it'd be great if that person was treated with PPI short term to heal that, but long term, if reflux has been a problem for a long time, or if that person can't be controlled off of proton pump inhibitors, then yes, that's when you should be seeking the care of somebody to consider doing fundoplication, the TIF, or a hiatal hernia repair. But as we said, it's only for those people that can't be controlled on H2 blockers and restricting their diet, who don't feel they have quality of life. You know, we can't do this procedure on every person in the United States. We have like 40 to 50% of people have reflux. So we need to be selective. We need to be responsible and do this on those people. So if people can take an H2 blocker, a Pepcid, and they can avoid the foods that cause problems, then great, you're fine. But if you can't avoid those foods and those medicines aren't helping you, that's when you need to seek care.
Perfect. Thank you. Oh, you hear me okay?
Yeah.
A little bit of an echo. Okay. So we've got another question from Kathleen. I have GERD and have had the barium swallowing test. They have me on Prilosec 40 milligrams twice a day. Anything else that can be done? I'm suffering with acid and food coming back up in my throat and my mouth. Have a TIF procedure.
Yeah. So there's a really good chance you've got a hiatal hernia, and there's this mechanic we talked about where the stomach is up in the chest. You've got low pressure there. That's high pressure in your stomach, low pressure in your chest. That causes reflux. So you really need to look into getting a mechanical fix for that. And then also make sure that you don't have the poor emptying stomach gastroparesis.
Right. And this is a common question I'm seeing from a lot of the viewers right now. They're saying they've tried everything. They're on antacids. They are taking Mylanta. I still continue to have GERD. What can I do next? And I mean, to your point, it's the same thing. They need to go see their physician, right? Their PCP and or GI, or even
yes.
So
have your doctor refer you to a gastroenterologist that specializes in this type of procedure, that we were able to actually address the underlying cause and give you treatment options so we can get you off your medications so that we can give you your quality of life back.
Yeah, exactly. Perfect. I do have one last question that before we kind of conclude. Rajesh is asking, and you did mention this a little bit, but maybe he jumped on a little bit later, but he's asking, doctor, is the TIF procedure advised for Barrett's esophagus as well as a hiatal hernia repair? So you kind of talked about that, but maybe you can answer it again for him.
Yeah, I mean, there's no reason if you have Barrett's that you can't have a TIF done in a hiatal hernia repair. As long as we're able to access it, sample the tissue. If you've got Barrett's with dysplasia, that really needs to be treated first. And that's a different subset. That's a very rare situation. Most people with Barrett's don't have dysplasia, but that's something that your gastroenterologist is going to know. And for those people without dysplasia, you can absolutely get this procedure done, and the Barrett's can be followed on a routine basis.
Fantastic. Thank you. So before we kind of conclude our TIF talk tonight, we didn't talk about, I want to just make sure we touch a little bit on recovery after the TIF procedure. Can you talk briefly about the recovery and any post-op recommendations or things? I know we have quite a few people that watch or come on and ask questions about post-op, the diet and
right.
When can they go back to all those types of things? So touch on that briefly. That'd be great.
Yeah, sure. When immediately after you wake up, you're able to drink water, and we really keep people on a liquid diet for the first few days. After a few days, people can start to advance to shakes, protein shakes and smoothies, and from there move to soft foods, and eventually it can take really up to 4 weeks before people are swallowing solid food normally. And realistically, people lose anywhere between 10 and 15 pounds after they have this procedure, which, if they want, they regain fairly quickly. There are a lot of people that are happy about that, I have to say. And we know that weight reduction actually helps reflux as well. But it is a procedure that takes a bit of time to recover from. There's swelling and edema that occurs at the area. It's not that they're going to disrupt the surgery. It's just that there is a change in the way that the esophagus is able to handle food for the first few weeks. And but after 4 weeks, the vast majority of people, they're off their reflux medications. They're having no reflux. They come and see you and they're like, oh my God, I feel amazing.
Yeah. Yeah. And I think that's one of the things I see on these community boards and groups. They talk about it, I'm 4 weeks out, or I'm 3 weeks out and I still have reflux, or even sooner. Every patient is different, right, in their healing process. So for most, it could be 4 weeks they're feeling better, but sometimes it takes a little bit longer for them to heal and get to 100%.
It does. It's also a little bit dependent on how it's done. Some surgeons may use mesh. Some may make a tighter repair. There may be some people that have problems swallowing out 6 weeks. There's the ability to go in and dilate someone's esophagus if that's the case and actually improve the situation. And we've had that happen where we've done it and people get better. There are people that do well and are great just after 2 weeks. So, I mean, there's a spectrum.
Yeah.
And there's not everyone is going to have the exact same experience, but we really have to look at the data because we always get anecdotal information. People always have a story to tell. But if you look at all of the people that have been treated with this over the last decade, and you look at how people have done and the complications and the recovery, in general, vast majority of people are off their medications, doing well after 4 weeks.
Right. And there's been over 25,000 procedures done in the U.S. to date. So, yeah. So, well, thank you so much, Dr. Freilich, for joining us tonight. Is there any last recommendations or anything that you'd like to say to potential patients that might be watching? What can they do to advocate for themselves, to help them? I mean, our whole goal of the TIF Talks is really to let people know, you don't have to suffer anymore. There's options now, and you have options. You can go seek a physician and ask for different treatment options if one's not working for them. But do you have any recommendations or anything that you want to leave tonight?
Yeah, I mean, I think it's exactly what you said. Don't suffer anymore. I mean, if this is something that's been going on your whole life, there's options to take care of it now. I mean, unfortunately, proton pump inhibitors cause long-term problems. We saw that Zantac, there was a batch of them that came out with carcinogens in them, supposedly, although I think that's also a little soft on that data. But it scared enough people where now there's a shortage of Pepcid. So we prescribe Pepcid to people and they're sold out at the pharmacies. So now we're having to give people the oldest drug, the very first drug that came out, which was Tagamet and cimetidine, and it still works great. But, this is what we're seeing is that recognize the medications are not something that the proton pump inhibitors that we can have people on long term. And realistically, people like to eat what they like to eat. They like their coffee in the morning. They like their orange juice. They like eating pizza and they like barbecue. And when you have reflux, you can't eat any of that. So if you want to be able to enjoy your life and not have a restricted diet, this is something to consider.
I couldn't have said that any better. That was beautiful and true, right? So again, Dr. Freilich, thank you so much for being with us tonight on our TIF Talk. We really appreciate your time. I know all of the patients that are on Facebook, if you go back later and watch it, people are saying thank you so much and thank you for all the information. So, I mean, that's our goal, is to try to give our patients as much information so they can make a decision or like we said, advocate for themselves. So if you are in the Kansas City area, that's right, where you're in Kansas City, what area are you?
Yeah, I mean, the Kansas City metro area, actually, I mean, kind of in the heart of the Midwest, if you're in the heart of the country.
If you're in the heart of the country, yep.
Yeah.
You can go see Dr. Freilich. But if you're not, you can go to gerdhelp.com. We do have a physician finder on there, and you can type in your zip code and you'll be able to find a physician that's near you that does the procedure.
And just to advocate for our practice, we have two other physicians, Dr. Jaffrey and Dr. Saeed, that are doing these procedures as well. Very experienced, excellent doctors. So we really have the capacity to see people.
Fantastic. Well, thank you again so much, Dr. Freilich, and thank you everybody that joined us tonight. We really appreciate it. We do have a special for you guys, so if you're watching and you want to ask more questions, if we didn't get them answered today, we do have another TIF Talk tomorrow, which is unusual, but we have another TIF Talk tomorrow from doctors in Arizona. So you're welcome to jump on tomorrow for our TIF Talk. Again, we can't thank you enough, Dr. Freilich, for being here tonight. And everybody stay safe and have a great evening. Thank you very much.
Thanks, everybody.
Thank you.